I'd like to welcome everyone as you're joining to the KCQVIC Forum. These are our monthly forums where we get to bring together a number of different stakeholders and discuss, important healthcare priorities and topics for our region and really for our nation. And so we have a really great lineup today on long haul COVID, which is a really important topic. So very excited to discuss that and hear from all of our speakers today. I'm going to share just a few slides of background for everyone on what the KCQVIC Forum and our institute is, and then I will kick it off to the speakers. And I also want to encourage everyone on the call to please utilize the chat feature of the Zoom. We really want to have a dynamic discussion at the end and also, during the presentation. So if you have any questions for any of the speakers, feel free to put those in the chat and we'll monitor that during and as well as time at the end for some Q&A and discussion. So with that, I just want to share that the Kansas City Quality and Value Innovation Consortium, we have a vision of Kansas City delivering the highest value, most equitable healthcare in our nation. And our mission is to catalyze and facilitate multi-stakeholder collaborations to improve the quality and value of healthcare. And we're supported and partnered with some of these institutions and partners here at the bottom. And so, we all kind of know this, right? That currently in the US, we're operating under these shifting payment models where we currently operate, in fee-for-service, where we're focused on volume-driven healthcare. And, through necessity, really, we're trying to move to value-driven healthcare where we're increasing the quality of care that we're delivering while reducing costs. And what we've done here with the QVIC is created a regional strategy where we have created the QVIC, which is really a partnership of different stakeholder types where we bring together the providers, different researchers, purchasers, being employers, and also the commercial and federal payers, as well as community partners and patients. And we're really trying to bring everyone together to think creatively and to innovate in bringing evidence to healthcare and then to communities as well. And that way we can all kind of tackle this, I guess shark we're calling it here, but this changing healthcare, that's the healthcare delivery and payment systems. And within the QVIC, we have really three main strategies by which we are trying to accomplish our goals. So the first of those is we have these regional quality improvement projects. And so after surveying, the region to really understand what the healthcare priorities were and what all of our health partners were already focused on themselves, we decided, and we came up, honestly, after surveying them, meeting with C-suites of hospitals, with payers, et cetera, we had 32 different kind of quality improvement focus areas or topics, and a number of qualitative areas and methods. We pared that down to two different projects. And the first of these was opioid management, and the second is transitions of care for heart failure. And these are our, regional quality improvement projects in which on the left here you see a map of Kansas City, and in the red is our opioid project, and in the blue is our transitions of care project, and these stars represent the hospitals at which we are partnering with to implement these evidence-based interventions. And I'm sorry, I got a little distracted. My kids are running around. I'm really sorry, guys. Snow day. Okay, so our first is the regional QI projects. Our second main area of focus is training, because in order to actually do these regional quality improvement projects, we need to make sure that we understand implementation science, or the real science of how we actually implement evidence into healthcare and communities. And so we developed a training program called TIARA, or Training and Implementation Actionable Research Approaches. And we're also moving into new phases where we're trying to make this both training and education, both for, for credit institutions and academic training, but also more pragmatic training and professional training for healthcare, for people who work in public health, but basically to help with implementing evidence into care and communities. And then the third of our activities is dissemination and engagement. And that's where we focus a lot on the KCQVIC Forum, which is our monthly forum, and here today what everyone is here for. So those are our three main strategies. Last year, we kind of created a home to house these QVIC activities. And so we are now housed within the UMKC Healthcare Institute for Innovations in Quality, or HIIQ. And so really what we're doing with the QVIC is we're creating, moving away from kind of the learning healthcare system, where a hospital kind of learns and changes within itself and improves over time, to trying to create a learning healthcare community where we partner with all of the stakeholders so that ultimately what we can do is improve the outcomes for patients. And then today, everyone is here for the KCQVIC Forum. So again, a part of our dissemination engagement with the community. These are just wonderful. I love these events. And today we have long haul COVID, but here I'm just showing you kind of the lineup for the whole year so you can see which other ones you want to tune into, or if you have any speaker recommendations, do feel free to send them to Pat or myself, or put them in the chat because we would love to hear those as well. And so with that, here's the agenda for today's session, and I have the pleasure and honor of turning it over to our first speaker, who is Dr. Harlan Krumholz, who is a cardiologist and director at Yale New Haven Hospital Center for Outcomes Research and Evaluation, and I know a dear friend and mentor to my mentor, Dr. John Spertus. So delighted to have you, Harlan, and the floor is yours.
Oh, thanks so much, and what a pleasure to be here. I feel like I'm part of the community, and it's nice to see friends like Ed Ellerbrecht join today. So thanks, Ed, for coming and taking a listen to the presentation. I'll try to, let me see if I can get this up. Everyone see it? Okay, I know these are just really brief presentations, so I don't think I pressured speech. I'll just try to go through this really quickly and share some insights and show you some of the ideas that we're working on. So I just say long COVID, a path forward. So I can do this. So a disclosure, I'm going to be talking about a health platform that I was co-founder of startup, and I want to just disclose that. It's built to enable people to gain agency over their health data and leverage it for research, peer support, and learning. And you'll see what I mean. So look, this was as recent as yesterday that this came out in Science, and raising this question about pandemics disable people. The history lessons that policymakers ignore. Influenza, polio, more have shown that infections can change lives even decades later. Why the complacency over the possible long-term effects of COVID? CDC defines long COVID as a wide range of new, returning, or ongoing health problems people can experience 4 or more weeks after being infected by SARS. Just to level set, a growing body of research has linked long COVID, which can affect over 1 in 3 infected individuals, with over 200 potential symptoms that people report and afflict over 10 organ systems. The sequelae can persist for months, generating a host of risks to Americans' health, the economy, and even national security. A lot of us believe this is a big deal. The fact you're having a session on it today, I think, indicates that you may agree, and it's something that should compel us to action. If COVID is to become endemic, then the growing incidence of long COVID will become inexorable, and the resulting morbidity may ultimately become one of the largest and lasting population health impacts of the pandemic. It's really something that we can't ignore it by any means. However, the American healthcare system, and indeed society at large, is distressingly unprepared to address the rising tide of long COVID. And you'll see a lot of articles. I'm really glad that today you'll hear from someone who's experiencing this. The stories are quite compelling, and many of them from people who were quite healthy before. This is something, I know it's in people, but this is emblematic. Runner 29 with long COVID went from half marathons to months in a wheelchair. It was so scary. These are not sensational National Enquirer headlines. These are real people experiencing real problems. Long COVID's destroying careers, leaving economic distress in its wake. This is Washington Post, a profile of a large number of people. This is from an article in NPR that was someone who was in one of our studies looking at people who were complaining of internal tremors and vibrations, and symptoms that people didn't quite know what to do with. Lisa Fisher, but previously extraordinarily vibrant, healthy, active individual who life was changed substantially. I was quoted in this article, and I just want to say that what I said is, and what I will say to you is that I've been taken aback by the depth of suffering in both the study data and in the patients that I've seen. The degrees to which patients are having their lives unravel from the new set of symptoms is remarkable. The similarity among patients who never met each other speaks to me to the likelihood that there are some real, genuine syndromes. Lots of people want to dismiss the kind of symptoms that they're hearing. And when I hear this suffering and I hear the consistency of symptom clusters, the stories that people tell, I'm convinced there's something we need to pay attention to. I said, when it comes to the issue of patients not being believed by physicians, a common complaint of long haulers, I think that the doctors are facing a predicament. We're trained that when we see patients, we try to match them with what we know in the medical literature. We try to match with what we've seen before. When people come in with something entirely new that doesn't fit a pattern, on our side, on the doctor's side, there's a sense of inadequacy and frustration, and we don't know what to do. And unfortunately, sometimes that manifests itself as a dismissiveness. And then for patients who feel lost, I said, we need to try to help people know that they're not alone. Some people are asking, am I the only one in the world who's got this thing? It seems unusual. No one seems to know what it is. And we need to help them know that they're one among many who seem to be experiencing these kind of symptoms. And so our group, we're continuing to work to connect groups of patients so that they know they can get support, and then work with researchers to accelerate enrollment in studies and learn to identify immune signatures that I'm going to talk to you about that might be at the root of some of this. So in summary, I think we're facing potentially a generational health challenge, not just the COVID and pandemic itself, but what that long tail where people are continuing to be affected. And yet we have an abyss of ignorance and an urgent need to mitigate suffering and an imperative to accelerate learning and a danger to people in society if we delay. It's long past the time that we really need to invest in this. Now, this platform I talked to you about, which is really a tool of empowerment for patients, where how can people get agency over their data and be in a position where they're not just looking for studies, but they've actually got data that they can contribute. But these studies need to be built to recognize them as true partners, respect and honor their participation, and guarantee that they'll know the results will be returned to them. They'll be part of the group that's learning. So our approach, both at Yale and on this platform, is to try to bring people together as a community in a safe, secure platform where they can share trustworthy information, and we can help combat misinformation. There's plenty of it. And when people get desperate and they've got symptoms that people aren't recognizing, the chance for misinformation and then mistreatment and mishap grows tremendously. We need to be able to enable people to create health profiles with their health data and surveys and match them to people who are experiencing very similar manifestations, so that people can provide the kind of peer support, but be able to maintain their privacy. So by authenticating that others have these symptoms, you can make groups, but people don't have to necessarily reveal their names, but they can be confident that these are people who are experiencing similar things, and then provide opportunities to join high quality research that treats them as partners, that treats them with respect. So we're about to launch this idea, this platform, this community that we're calling Kindred. And we're calling it, leveraging ethically sourced data. So using this technology, this tech stack we have, people are able to use their own data to connect with others and build this sort of consumer health network that is poised to be part of a research project, poised for people to be able to provide each other peer support and to connect with others who have similar interests and are facing similar challenges. And the idea is to bring together these people, researchers, scientists, clinicians, and race for the kind of answers that we need, while at the same time providing understanding, support, and tapping into the wisdom of the patients who are facing this. Right now, they're the experts. They know better than anyone what this is. You can't find any textbook chapter that explains what this is or what people experience. It's contained, sequestered within the lives of the people who are experiencing it. So we've got this platform set up so we can do e-consents. We can bring in health system data, pharmacy data, provide surveys, get payer data, wearable data, sensor data, all of that on behalf of the individual. And then no data moves without people's permission. But if we can create the means by which they can work with trustworthy partners, then we can create a pipeline of knowledge generation that can go quite quickly. So the key principles of this new model is develop this as a community, be worthy of trust, seek diversity and inclusion, moderation of the content to create a positive culture and combat misinformation, partner with people to learn rapidly, promote research that puts participants on the team. They're not subjects. They're not guinea pigs to be studied. They are part of the team. Protect the data and ensure everything with regard to data is permission-based. There's no cell on the backside. There's no data moves without people's permission. And commit to transparency and open science. So I think just in the interest of time, I won't go into this, but there's a beginning where someone feels alone, and then they can find other people. They can find reliable information. They can link with researchers who are doing science. And there's not anyone who owns this community. It's not Yale. It's not Hugo. People own it. It's about trying to bring people together and find these kind of partnerships. And then we've got a study that we're about to launch, which is where we're going to try to bring people in from this community, where we can characterize their symptoms and identify clusters and figure out people who have got the most extreme symptoms. And then working with Akiko Iwasaki, a world-renowned immunologist, see whether or not some of them are willing to give blood and have their immune system profiles be characterized in ways that we can see what's up and what's down. I mean, what's activated and what's not, what's just like everybody who's not feeling symptoms, and what's unique and distinctive about the people who are feeling these symptoms. So these immune signatures, see how they correlate with the symptom clusters, and see if we can then identify potential targets for diagnostics and therapeutics, and see if this will also produce tools that doctors can use to be able to help guide people, track their progress, and then as diagnostics and therapeutics come out, link them appropriately. There's another facet to this, and I'm just about at the end, so I'm trying to be attentive to time, that with permission, we can de-identify data and provide a path to share this with other researchers. Again, this isn't a path traditionally in academics. We do a study and then that's my data and I get to write all the papers. And we're trying to instill a culture that we need to work together, hold hands, and make progress as fast as possible. If you're facing these health challenges, you want as many smart people as possible working on this. And that includes both the people with science and PhDs, but also other patients who may have insights into the things and the questions we should be asking and the things we should be studying. Enable other studies to recruit. This isn't just for a small group of people to be able to let people know that there's studies they can enter, but if these studies will commit to treating people with respect and returning results to them and treating them with dignity and as members of the team, then they should be able to offer to the community opportunities to be part of it. It isn't about one scientist or one science group having that access. It's about trying to create pipelines of knowledge. And in Gender Spirit, where we're on the journey together, we need everyone working together to make progress. And if this works, we'll have introduced a new way to produce actionable knowledge rapidly, research that fosters community, promotes connectedness, and produces results while supporting people with information, peer support, and assistance. This is what we're driving to, a new paradigm of how research is done, a paradigm that trusts and engages people in a way that again, creates community and value for them. So I say, all for one and one for all, united we stand, divided we fall. This came from Three Musketeers, but it's that all members of a group support each other and that the individual members support the group, and that there's a common mission that everyone's seeking to accomplish together. That's progress, that's diminish the suffering, and let's get people back to where they were before all this happened. So thanks for your attention. I just wanted to share a bit about what it is that we're doing.
That was wonderful. Thank you so much, Dr. Krumholtz. If anyone has comments or questions they want to put into the chat, Dr. Krumholtz does have to take off in a little bit, but just be sure to pop them in the chat if you have any questions for him. It just, so incredibly important, the power of community and the need to build trust in research. We've seen so many things in our history that have seen how we've failed at that, and I think that's such an important aspect to focus on.
And people can email me also if they have questions that they can't quite fashion now, but it's just harlan.krumholtz@yale.edu. So people can always feel free.
Okay, and we can drop that in the chat too. So,
and if people want to, we're going to, put this out probably within a week or 10 days. We're also going through the IRB for the Project Listen, and if of patients that are interested, they can also contact me, or we can provide a link and they can see. And like I said, this is really about partnership. So we're going to try to everyone learn together.
Great.
Yeah, I think that's what I was going to ask about is how to connect as this rolls out. But I think if you can get the information to Stacy out, she could potentially circulate that out to the group.
That'd be great if people are interested. That'd be wonderful.
The fascinating concept.
And anyone can email me too, and I'll be glad to then get it, or patients or anyone who's interested. I'm glad to help facilitate. Thanks, Ed.
Wonderful. Well, thank you.
Thank you all, and hope you all get through the snow.
Yes. All right. And so for our next perspective, we're going to turn it to hear kind of from the provider perspective. We'll be hearing from Dr. Brandon Comfort, who's Assistant Professor of Medicine in the Division of General Geriatric and Hospital Medicine at the University of Kansas Health System, and I know is working on a long-haul COVID clinic that he has started up. So he'll be speaking on clinical symptoms and treatment for post-COVID conditions. The floor is yours, Dr. Comfort.
Okay, can you all see my slides okay and hear me okay?
Yep.
Okay, thank you. Well, thank you all for inviting me. This is such a great forum. I'm happy to be here. Really enjoyed, exciting concepts from Dr. Krumholz there. And so I'm, as someone who's seen a lot of long haul patients, I can tell you I'm very interested in any sort of way to connect. And I can tell you the patients that I've seen are very engaged in participating in research and being an active kind of role in that. And so I think that's a really exciting. I think it's going to be great. So yeah, I'm an internal med doc at KU, and I've been one of many. We have a lot of, pretty much every department is involved in our post-COVID efforts. And so I'm just kind of one of many kind of representing the provider side. And so we've seen several hundred patients at this point. I think 600 and some have come through our official workflow at this point. And we know that that's just barely scratching the surface. And so I'll tell you what we've learned so far, and then we'll kind of go from there. So I always start out with this slide just to kind of give a little bit of background. And so, this is what's tough about long COVID is that, one, there's no accepted definition of this. There's no accepted terminology. We hear different things all the time between long COVID and post-COVID, post-acute, sequela of COVID-19. You'll hear many, many different terms, but what we can all agree on is that what we're seeing are a huge number of patients. They're having ongoing symptoms long after we think that this virus has been in their body, basically. So we all know we get the SARS-CoV-2 virus, usually over a couple, 2, 3, maybe 4 weeks or so. We typically clear the virus, at least in a way that we can detect it in the nasopharynx or respiratory tract, but yet there's many people suffering from ongoing symptoms. We've seen people now that are not just months of having symptoms, but we're really moving into the years sort of category. And so I think, as Dr. Krumholz alluded to, this really seems, this is going to be a huge public health burden. It's going to put a lot of strain on a lot of our health systems. So what are the symptoms that we're seeing? So, I think this depicts it fairly well here, that the number one symptom that people are bringing to us is a fatigue. And what we have seen is that this is a different type of fatigue than I've seen in other conditions. This is a very debilitating, profound fatigue. Many of our patients are not able to work full time now. Many of them who are younger patients having trouble taking care of their kids, doing their day to day, getting back to their everyday activity. Fatigue has been a huge symptom that we've seen. A lot of pulmonary symptoms, cough, shortness of breath, neuropsychiatric symptoms. So I think it's been pretty well covered in the media and other places about this post-COVID brain fog. And this is a real thing. About half of the patients that we've seen at KU for long COVID are reporting some sort of cognitive disturbance. It's really quite alarming. Sleep disturbances, heart problems, racing heart, chest pain, thromboembolic disease, chronic kidney disease, hair loss. I mean, you name it, it's really a multi-system disease. And we've kind of seen the gamut of symptoms over time. So I think Dr. Satterwhite will probably cover the epidemiology in much more detail than me, but I'll have just a couple of high overview slides on this. And so it's tough to say for sure how many people are suffering from this. The studies, because we don't have a universal definition or terminology, all the studies have been set up differently so far. So we have some that are looking at patients who are hospitalized, others just ICU patients, some are looking at all comers. And so we see a wide variability depending on which study we're looking at. The best estimates, though, are maybe up around a third of people are experiencing some form of post-COVID condition. Some of the more conservative estimates are down around 10%. But even at the low numbers of this, we're looking at large numbers of patients. I like this particular paper. This was one of the few kind of prospective studies that we've seen on this to kind of give us a sense of how common or how long some of these symptoms are lasting. And so this was published probably last year sometime in Nature Medicine. I think it tells us a couple of important things. So this study was set up differently than some of the others, that patients were diagnosed with COVID and then they were entering their symptoms into an app. This was based out of the UK, and they followed that out until basically people stopped reporting symptoms. And so there's a couple of important stories that I think this shares, which is number one, as the weeks go by, less people are having symptoms. And that is very consistent with what we have seen in our clinics. But the downside of this is that this is easily the most conservative estimate that I've seen. And even at that, if 2.3% of people have symptoms for greater than 12 weeks, we're looking at tens of thousands of patients just right here in our region that are likely suffering from long COVID. And chances are it's much, much higher than that, because I think, like I said, this is easily the lowest estimate that I've seen on this. So there's a few risk factors that we're starting to see come out, or that have been reported in the literature so far, that increase someone's likelihood of developing long COVID symptoms. And so first one is severity of their acute illness. So people who need the hospital, people who need ICU level care, or the people who need to be, it requires some sort of invasive ventilation, tend to have a higher chance of having long COVID. And I think that makes sense. These are patients that really have significant illness during that acute phase of the disease. And there's a few premorbid conditions. There's a few more studies starting to come out on this. So I think we'll know more in the coming months, but pre-existing respiratory disease seems to be a big one. So particularly asthma, COPD, those who struggle with obesity have a higher risk of this, and older age. And so, with that being said, these increase people's risk, but we've seen a whole lot of young, healthy, active people who are not able to be as active as they were before they developed COVID. Patients always want to ask me, how long is this going to last? And the short answer, like almost everything with long COVID, is we don't really know yet, but we fear that it's going to be quite a long time. We're starting to see some papers published now looking at 1-year outcome data. The stuff that's been published so far has really been focused on patients who were hospitalized. So again, people who were much sicker during that acute phase of the illness. So this is just one that I decided to show, which was published in the Lancet here, 1-year outcomes following the cohort out of Wuhan, China. And as you can see here, that 68% of people had symptoms, or at least one symptom, at 6 months, and 49%, so almost 1 in 2 people, were still reporting some symptom at 12 months. And so again, if we just start to think about the how many people are going to be needing care in the future, and for how long, the numbers really start to stack up pretty quickly. We do know from SARS-CoV-1 as well as Middle Eastern respiratory distress syndrome, they had similar post-viral conditions. And in that, so maybe we can extrapolate a little bit from that, because it does look relatively similar. Symptoms for many people were being reported up to 4 years out. A lot of the studies kind of fell off after that. And there was one that showed there's a radiographic complications up to 15 years out. And so, I think the point, I think Dr. Krumholz made that point already, but, I think we're worried that this is going to be a large public health burden for many years to come for many of our patients. So the pathophysiology, so the why, right? So why is this happening? And this is the great question, right? So, I think Dr. Krumholz made a really interesting point about a lot of patients that we're seeing, they're reporting such similar symptoms. The symptom subset, in a lot of ways, it really lines up almost more consistent than what we see in a lot of other things. So we may not understand the biology yet, but there is clearly something going on here. And I think there's a lot of research in this domain right now. And hopefully over the coming months, we have a few more answers on this. There seem to be about 5 main mechanisms driving some symptoms. And so some have started to argue that really this isn't just one syndrome, post-COVID syndrome, but maybe there's some subset of syndromes or different entities entirely. But I kind of started down on the bottom left here where, the one that's probably the easiest for us to conceptualize is people develop organ damage during the acute phase of illness. And so that one's probably easier. People have lungs that are damaged or their heart is or something like that. At least we can understand why they may have ongoing symptoms. And so we do see a number of patients with that, but that does seem to be the minority. There's some evolving evidence around viral persistence. And so this has brought up an interesting concept. I can't tell you how many patients I've had tell me that it feels like the virus is still in them, like months afterwards. They'll say it just feels like it's in them. And so there's some evidence that that's probably true. And we see that with other viruses like, HIV, you can get viral reservoirs and things. There's been studies finding this in the GI tract for many, many months, in the central nervous system, particularly in the brainstem, which is a really scary thing to think about. But basically anywhere where there's high expression of these ACE2 receptors, which is GI tract, central nervous system, pancreas. So we've seen a lot of diabetes that gets really more difficult to control afterwards, that they've found evidence of viral persistence in there. And then there's this idea of persistent inflammation. And there's a lot of interest in this in particular. A lot of our patients will describe this kind of waxing and waning pattern. Sometimes they wake up one day, they feel good. They wake up the next, and all these symptoms have come back, and they may even feel fevers and other kind of inflammatory type of symptoms. And there is a number of papers that are starting to come out that are showing different areas of the immune system are persistently activated for many months after they're infected. So this could tie to that viral persistence. It may be something entirely separate where COVID just messes with our immune system's ability to regulate itself. Then there's autoimmunity. This is a small percent of people, but this is where our immune system actually attacks our own cells. We've seen a couple of that, but that's a much smaller. And then another big category is exacerbation of underlying medical and psychiatric illness. And so, if we take obesity, for example, that we know we have an obesity epidemic in our country, and people then get sick with COVID. They have exercise intolerance. They're not able to get back out there and exercise and other things. Their obesity gets worse, and we start seeing all these other complications from that, like sleep apnea, diabetes, heart disease, et cetera. And so that's a big category that we're seeing as well. So our approach to patients who are coming in with symptoms, it's similar to what we do with other patients. And so I show this slide. It's kind of a busy slide, but this is really the article that has framed our approach at KU, at least within our clinic. And so this was published in the British Medical Journal fairly early on in this, actually. This was published in late 2020, and I think it's still very useful for us. Patients come in, we're going to do all the usual stuff. We're going to take a history, we're going to check their vitals, do an exam. We may get some routine type of blood work, blood counts, and checking their liver and kidney functions, things like that. Depending on their symptoms, we may do a little deeper dive. We do all of this while trying to manage their comorbidities. As mentioned before, we try to take it in context of their social and financial. We certainly have to take care of their mental health as we're doing this. And then we pull our specialty colleagues in, really when we're finding organ damage. So in the lungs, heart, brain in particular. So we've been able to distill our approach down. I like to think fairly simply. I'm kind of a simple guy. So I think if it's easy for me, if I can think about this as easy in terms as possible. And so we've distilled this down to the 3 R's, so to speak. And so when we're seeing a patient, we really spend the first visit focusing a lot on ruling out severe organ damage. If we're not seeing that, we really flip into a rehabilitation sort of focus. And then research is a really critical component of that. I think as Dr. Krumholz alluded to, we need to figure this out so that we can have targeted treatments and really get people back on their feet quicker. So just as an example, we could talk in more detail on this, but we really when we're talking about ruling out severe organ damage, really focus on the big three: heart, lung, and brain. To a lesser extent, kidney and liver and other things, but a lot of patients have chest pain, shortness of breath, those sorts of things. We know that people can develop myocarditis, pulmonary fibrosis. So we're focused on making sure that we're not seeing any evidence of those types of conditions. We've ordered a fair number of cardiac monitors because a lot of people are having a lot of racing heart symptoms, tachycardia, and things like that. So we do order a fair number of cardiac rhythm monitors, pulmonary function tests, CT lungs when appropriate, occasionally brain MRIs. We were getting a lot more of those early on in this, but at this stage, we've most always it's been normal. And so we've kind of started to move away from that because it hasn't been all that useful to us from a clinical standpoint. If we're not seeing damaged end organs, we really flip into a rehabilitation mode. And this is really the core of our treatment at this stage. And so our rehabilitation department has really carried the heavy weight of this. And to date, this is really the only thing that has any evidence, at least in the literature, of getting people through their recovery quicker. And so exercise intolerance fatigue, we'll have our physical therapist work with them to develop individualized exercise programs. For patients suffering from brain fog or this cognitive impairment, speech therapy has been absolutely critical. And so I actually have a picture here. This is a patient of ours who gave us permission to share this slide or share his photo. Actually a physician here in town who developed COVID, had such severe cognitive impairment it's really led to a lot of inability to do his work and do his life's calling. He's working here with one of our amazing speech therapists, Jamie Johnson. They do a lot of these kind of cognitive kind of retraining and cognitive tricks to try to help him get through that recovery. We're starting to look into that to try to get a little bit better data on that, but at least anecdotally, our speech therapists are telling us that our patients are telling us that this has been really helpful in getting them through that. And then there's a big research agenda attached to this. So that's not really my area of expertise. I'm a clinician primarily, but I'll just tell you there's a lot of things happening here locally as well as nationally around the research agenda. We are one of the sites for the Recover COVID-19 trial. And so that's being ran by Mario Castro, at least at KU. There's sites all over the country. That's going to be a really important study. We have a brain imaging pilot trying to understand the brain fog. Pulmonary department's working on a biorepository, getting sputum samples and things like that to research. Our rehabilitation department, our cardiology department, everybody's kind of doing projects to try our best to try to understand this over time. I'll just show these just quickly. The NIH has really put a lot of effort or a lot behind this. So there's been over $1 billion allocated to researching post-COVID or long-term effects from COVID-19. This is just kind of a smattering of them that we can. If you're interested in that, you can kind of dive into more detail on that. And then just a quick word on pharmaceutical treatments. We don't really have anything that we're using pharmaceutically is a repurposed medication. So if they're short of breath, some people respond to, inhalers and things like that. We'll certainly prescribe them and try that. Some of these patients have symptoms very similar to what we see with chronic fatigue syndrome. So we may be able to use some of those medications. POTS or postural orthostatic tachycardia syndrome is really common. So we've had a number of patients that we put on typical POTS treatment, beta blockers, fludrocortisone, things of that nature. But at this time, we don't have any universal treatments. We really don't have any directed pharmaceutical treatments. The closest thing that we have is the vaccine. And so I'll just say a quick word. We think about vaccines as preventative tools, but when it comes to long COVID, there's a potential of a treatment effect to it. And so this is informal data at this point, like just survey type of data, but there's 2 of them out there that I've seen, and both of them showed about 50% of people report improvement in their post-COVID symptoms following the vaccination. And so when we talk about areas of research, this is going to be a really important area for us. And then certainly vaccines are helpful from a preventative standpoint of developing long COVID. So this was a study that was published in New England Journal with healthcare workers out of Israel, and they followed those who got a breakthrough infection. And 19% of them are reporting persistent symptoms at 6 weeks, which, for most studies that we've looked at, that is certainly a lower percent at that stage than most other studies. So we do think that there's a protective benefit of the vaccine. And then my last slide here is just some resources for patients. I don't know if you have any patients on the line or providers that are kind of looking for places to kind of direct it. I know Dr. Krumholz gave us another resource for our patients, but I think these have been two that have been particularly helpful for patients of mine as they're trying to find this community, learn as much about this, and start to contribute with this. So with that, I'll take any questions now or at the end as well.
Great. Thank you so much, Dr. Comfort. That was amazing. Not only your presentation, but just what you're doing here in Kansas City for patients who are going through this. So thank you so much. And yeah, just a reminder to everyone to, drop things in the chat, and we'll address those in the Q&A in just a little bit. And then in the interest, I guess, of time, we'll keep going along, and then we will have, again, Q&A around 4:10. And so next up, we have the honor of introducing Megan Boyle, who is a learning domain analyst with Cerner, and she is sharing her experience and her journey with long haul COVID with us. So we are very grateful and honored to have you, Megan, and thank you so much for sharing your experience with us.
Thank you. I'm just a tad bit nervous, so bear with me.
It's a friendly group, and we're here for you. Thank you so much for
not usually great at like the all eyes on me thing, but I have the computer, so it makes it a little bit better.
Hide our faces.
I know, I'm like, oh, I got this. So I first got COVID in October of 2020. And I have my notes here because it's been so long since then, to keep me on track. So that's why I'm kind of looking up at my other screen. So when I first got COVID, it kind of felt like a mild cold, kind of like allergy type symptoms, which I hear is very common. This was like 4 days before Halloween. So the kids were all excited. We were actually going to go trick-or-treating because I felt like it was mildly safe since we were going to be outside for the most part. Yeah, just the allergy type symptoms at first. And I thought nothing of it. And the only reason I got tested was actually because we were going to have my daughter's first birthday party that weekend. And I was like, you know what, just in case, I should probably go take a test. I don't want to end up spreading it to everyone. So the test came back Wednesday, the 28th, and it was positive. And I was kind of shocked. I was like, you know what, I've had sinus infections worse than this. It didn't even feel like anything at that time. But 2 days later on a Friday, I was like, okay, this is definitely COVID. I had the weirdest headache. It almost felt like my brain was on fire. It was a really weird feeling, really bizarre, something I've never felt before. I lost my taste and smell that same day. I just started getting really fatigued and the brain fog set in. I was in a college class at the time and I had to email my teacher right away and say, I can't even focus. I actually ended up taking 2 weeks off of the class because I just couldn't even think straight. The fatigue never got severe to the point where I couldn't take care of my kids or anything like that. But it did. My cat's going crazy. I'm so sorry. You can hear him probably meowing. It never got to the point where I was super fatigued, but I just, like I said, I had trouble thinking. So when it came to a homework assignment or studying, I was like, I can't even bring myself to do this. And luckily, after a couple of weeks, that kind of started to fade away. I will start off by saying I'm a very healthy person. I've always been very active. I was an athlete, still continue to exercise regularly. I'm kind of crunchy in a sense that I like to try everything naturally before I go the medical route. So I eat healthy. I drink a lot of water. I do drink coffee, but usually limit it to 1 cup a day. So overall, I've always been very healthy. I've never had any issues. So it hit me pretty hard. I started getting blurry vision, shortness of breath. I started getting really bad chest pains when I would take a deep breath, which was really weird. I've never had that. And it was actually at rest because when I got COVID, I would go outside and walk a little bit around my yard just to keep my lungs active and open and fresh air and everything. And when I would come back in and sit down, that's when I would take a deep breath and I'd get the chest pains and the pleurisy is what I eventually was diagnosed with. But so I'm trying to read and see if I missed anything. I got a itchy rash all over the back of all over my back, and then actually ended up being on the front of my calves for some reason, which I thought was extremely weird, but I did develop like a really itchy rash with it. My lymph nodes were swollen, like in my armpit area really bad, and in my neck. I was having extreme blood sugar dips, which was kind of crazy because Dr. Comfort mentioned the pancreas and the diabetics who have a hard time post-COVID. And I've never had diabetes. I've never had blood sugar issues, but I would get really bad dips to where my vision would completely go out and I thought I was going to pass out. And it was really scary. I'd never experienced anything like that before. And it would always be like if I had something too sugary, or if I hadn't eaten in like 2 hours, which 2 hours should be fine. If you are drinking water, you should be able to go a couple hours without eating. But yeah, those were pretty scary episodes. I almost had my husband call 911 twice, because at one point I was holding my hand in front of my face and I couldn't even see it. And I was like, I'm going to pass out. You're going to have to call 911. And luckily he got me something to eat real quick and I came back to. But just super scary stuff for being a healthy person during COVID. So I was expecting it all to just kind of get better over time. And then a couple weeks went by, I was still having the pleurisy. Oh, I forgot to mention, I did end up going to the ER and stayed overnight because the pleurisy got so bad that it was going to my shoulder and up my neck on one side, on my left side. And I thought I was having a heart attack. But they did EKG and they checked for blood clots, and they did an ultrasound of my heart, and all of that looked normal. So that's when they diagnosed me with the pleurisy. And that continued. It continued for months and months, the pleurisy. When I took a deep breath, the sharp pain, what's weird is it went from being on both sides to just one side, my left side. But so all that to say, I was in my primary care physician's office more than I've ever been in my life following COVID, trying to figure things out, blood work. She prescribed an albuterol inhaler, which I heard Dr. Comfort say that. That made me feel awful. It made me get like tingly nerve pains down my arms and into my fingers. It made me really jittery and feel sick, kind of nauseous. So I was like, I'm not doing the inhaler anymore. She tried to get my smell and taste. She said that at one point, doctors are saying that a steroid nasal spray might help with smell. And so I tried that for a while and it didn't do anything for me. So finally, she suggested that I go to the post-COVID clinic at KU, which I did end up doing that. And when you schedule with them, they have a person call you and they ask you about all of your symptoms that are still lingering. And they get you to the right doctors to kind of assess what's going on, if there's anything they can do. I'm looking at my notes here because I saw several doctors in that time and I just want to make sure I hit it all. I had like joint pain and muscle pain that was kind of lingering on too. It almost felt like restless leg, but during the day too. So like almost like I was getting Charlie horses on my calves. And exercise did help, but it was still happening. So it was really weird. So one of the people they sent me to, one of the teams was the rehab team. And they did a bunch of x-rays on my joints and they ruled out anything kind of crazy. They did find a bone spur on my hip, which was not not related, but I was having quite a bit of hip pain just from that bone spur, like irritating the joints and probably the inflammation from the virus and stuff like that. But I saw Dr. Comfort, who ordered a tilt table test for the dizzy spells that I was experiencing. And the tilt, and then I saw a cardiologist after that, but the tilt table test, I passed out right away and it was not a fun experience. I never want to have to do another tilt table test again in my life. But they told me that my heart rate didn't dip into critical levels. So they couldn't really find anything there because they said, although I did pass out, my heart rate was still pretty strong. So that was good. They didn't find anything critical there. I saw a pulmonologist who ordered a pulmonary function test. So I did that and that came back, and that was for the pleurisy, of course. And that all came back normal. And then outside of the post-COVID clinic, I also saw an eye doctor because I was having blurry vision. several weeks after COVID. They gave me eye drops with a steroid to help with the inflammation, because they said the inflammation behind the eye from COVID was causing the blurry vision, which actually the eye drop with the steroid did improve the blurry vision, and it ended up going away completely. I saw a rheumatologist as well to kind of rule out any underlying like autoimmune stuff that I might have. And she is at KU as well, and she's amazing. Dr. Pooja Budabe, I think is her name, but she actually found a slightly elevated ANA and a slightly elevated anti-RMP, which is like a marker for like mixed connective tissue disease. And then I also had a low white blood cell count, but I've had that since 2017. So that kind of makes me think that's why my COVID was so bad. But so just like one marker for autoimmune, basically with the anti-RMP, which doesn't, I mean, it doesn't make you think that anything's going on there, because a lot of things have to light up to say you have lupus or say you have this or that. And it was just one thing. So we kind of ruled out autoimmune. But I do continue to see her if anything weird comes up, or if I have lab work done and my white blood cell count changes and that sort of thing. I did get both vaccines because my primary care doctor suggested that. Just like Dr. Comfort said, she said that over 50% of people were seeing improvements with symptoms. And so I thought, why not? So I had both vaccines, and I was one of those people that unfortunately did not see a difference after the vaccines. Still had the pleurisy, the weird muscle and joint stuff going on. Like I said, the brain fog and the rashes and all of that weird stuff, the shortness of breath, all of those little things kind of like tapered off. But the main things that I had were the pleurisy and the muscle aches and pains. And pleurisy is pretty scary if you've experienced it and you're a healthy individual. Every time I felt that pain, I was like, something's not right, something's not right. But the vaccine didn't help with any of it. So basically all of my tests that I did through the post-COVID clinic, I have to say it was an amazing experience, and they did an amazing job of like sending me to the right people. But unfortunately, I just didn't get a lot of feedback because I didn't have any abnormal results. I was just one of those people that they were kind of like, your labs are great, all of these tests are coming back normal, so we really can't do anything more unless you get worse, kind of thing. And so I kind of just decided to take my health into my own hands in a way. I was like, well, COVID causes inflammation, so I probably have inflammation of some sort. So I just started doing an anti-inflammatory diet. And this was 2 or 3 months ago. So I cut out all GMO oils, like all the inflammatory foods, anything with preservatives. I kind of just took it upon myself to be even more healthy and more aware of what I was putting in my body. More water. I stopped my coffee shop addiction, which was hard. So just cutting that out, going to the coffee shop, not knowing what they're putting in my drink. I started eating like whole foods basically and cooking at home. And immediately I saw a difference with the joint pain, aches and pain, and the muscle aches and pains. And that alone was like, oh my gosh, like very eye-opening. I was like, well, it must have been inflammation if now I'm treating my body better and it's improving, kind of thing. I try to do the best I can, and I feel like I was already doing great, but you can always do better, kind of thing. So now that's where I'm at. I'm just kind of trying to figure out what I can do as far as my immune system and what triggers my immune system and what is good for my immune system. So that's kind of my next step, was to go get some lab work done to see like what foods cause more inflammation in my body and cause me to feel more sick. Which foods can I eat that will help my body and help my immune system and boost it? And I take supplements for inflammation like turmeric and alpha lipoic acid and just all kinds of different things. So that's where I'm at now with my health journey. all of the doctors that I saw were wonderful, and I could tell they really wanted to be of service to me. I just feel like it's figuring out the why, because everyone is so individual. And for me, it could be inflammation, but for other people, it could be a different story. So where I'm at with the pleurisy is I've felt it a lot less since going on the anti-inflammatory diet. It's not completely 100% gone yet, like the joint and muscle pain. But I was also with the joint and muscle pain still having the like restless leg type stuff going on too, before the anti-inflammatory diet. So overall, things are improving within the last like 2 to 3 months, but it's been going on 1.5 years since I've had COVID. And I will say with the vaccine, I'll end with this. Although it didn't help with my symptoms that were kind of lingering on, I did get COVID again right after Christmas, and I hardly had any symptoms.
Wow, thank you
I know that's a lot.
so much.
I probably missed a lot too, and
No,
very confusing with my notes, but
I think you articulated your journey extraordinarily well. I think, and I just want to thank you for your vulnerability too in sharing with this group. I think it's extremely important that we all hear and understand these unique patient journeys because, you know, this is something that's, you know, relatively very new, and, you know, the research is relatively young. And so I think that the more information we have and you know, venues like this where we can talk through some of that and start thinking creatively together is really important. Just so thank you very much. And I really hope that, you know, the steps you've been taking, which sounds like you're extraordinarily proactive and eager and taking charge of your own health, I think those are extremely powerful. And I think that, you know, hopefully there's more long-term treatment options that can also help, so that this is something that you don't have to grapple with your entire life. So, or
yeah.
however long these last, which we don't know. So, and that uncertainty can be hard, but hopefully we can get more answers. And thank you again.
Yeah, thank you.
And I see some comments coming in the chat, and please everyone do keep them coming. But we will now, you know, shift gears and we'll switch to hearing a different perspective. We'll now be hearing kind of the policy and public health perspective from Dr. Catherine Lindsay Satterwhite, who's the Regional Health Administrator for the U.S. Department of Health and Human Services, Office of the Assistant Secretary for Health in Region 7, which includes, I guess she has them right there on her slide, Iowa, Kansas, Missouri, and Nebraska. So Dr. Satterwhite, the floor is yours.
Thanks, Stacey. First, Megan, amazing. I know you said you were nervous. You do not seem nervous. So thank you so much for sharing that. I don't have a ton of slides that I'm going to spend a lot of time on because I think that Dr. Comfort and Dr. Krumholtz did a good job of framing some of what I was going to talk about. But I do want to start by showing this because I think one of the things that we have to remember, especially from a public health perspective, is the denominator. It's talking about how many people we're really talking about who have been infected with COVID-19. And we know, especially on this gigantic peak at the very end, that this is an underestimate. These are just reported cases. All those at-home tests are not reflected in these numbers. And we also know that in thinking about outcomes with death being the most severe, there have been thousands and thousands of deaths. But I think what we lose is these last two bullets on this slide. And that's that there's a range of symptoms and that your symptoms initially may not even be the same within days. And then we have this thing called post-COVID conditions that we're talking about today. And Dr. Comfort, I think it's great that you called it that. So I'm speaking from CDC's terms, it's post-COVID conditions. They use it as this umbrella term. And I think as we've seen from other people on this call, that it's really complex. And it's been called a lot of things, long COVID, long haul, long haulers, post-acute. But all of these things are under this umbrella of things that happen after you think you should be fully recovered. And it's a big list. Again, I'm not going to go through this. I think we've covered it, but it's not just one thing. And Megan's story certainly illustrated that it requires a team of medical professionals to try to address these conditions. So some challenges. And Dr. Comfort also talked a little bit about this. The studies are all over the place. There's different study methodologies, different study populations, different follow-up. Sometimes we're only talking to people once. We're not including control groups, and it's inconsistency in reporting. So what I'm showing here too is one of the CDC graphics from a little bit ago that we knew that people in general, so among adults with COVID-19 who didn't require a hospital stay, 2 out of 3 had at least one outpatient visit 1 to 6 months after diagnosis. So just looking at a very low bar for contact with the health system following what we wouldn't consider to be severe COVID-19 infections if we're defining severity as hospitalization. So I'm also, Dr. Comfort, I was so happy that you talked about this study as well. It's just one estimate of self-reported symptoms, looking at still 2.5% of people reporting symptoms at 12 weeks or more. And hospitalization is definitely a risk factor. We do see that post-COVID conditions more common among that population. Another important point from a public health perspective is at the very beginning, so when we're just thinking about SARS-CoV-2 infection, there are disparities. So we know that infections are not occurring equally among different subgroups of the population. So we anticipate that this is going to be the same thing for COVID-19, for post-COVID-19 conditions. So these severe outcomes are probably going to be exacerbated among some populations that have a lot of risk for a lot of different things related to health and socioeconomic conditions. We don't have a good handle on that because, again, our data aren't quite there. There's a lot of research being conducted and that needs to be conducted in this space. I also do, though, want to highlight kids. So I think we've heard a lot of different things about kids throughout the COVID-19 pandemic, with initially like, well, kids don't really seem to get it, or it's not as bad in kids. But we still have a lot of kids who actually, we do know, did get an infection. It may have been asymptomatic, it may have been symptomatic. And we do have some early data. Again, it's early and we'll have to see how well it holds up, that 25% of kids experience persistent symptoms. And it tended to be actually in this older age group. So 6 to, I'm trying to remember, I think it was 6 to 15, 6 to 18. And that history of an allergic disease was a risk factor in kids. And the most common symptom aligned with what we see in adults is fatigue. We also know that that was among hospitalized children, sorry. Among non-hospitalized children, we're still seeing a lot of post-COVID conditions, with almost 2% having symptoms lasting longer than 58 days. This is probably an underestimate. Kids have different recognition and different tolerance maybe for different symptoms. Acute COVID-19 also, so even the initial infection may not be identified. Maybe we aren't testing as well in that population as some adults. And a couple quick notes about longer term disability. So as Dr. Comfort mentioned, most patients' symptoms slowly improve over time, but they do persist. And the thing that I really want to highlight, even if we're only talking about 1% experiencing some kind of disability, and this could be a short-term disability where maybe even weeks or months that you're not able to return to your normal activities. But if we're looking at things that are longer, which we are, so hospitalized COVID-19 patients, 88% returned to original work by 12 months, but 12% did not. So even if it's 1%, these are enormous numbers, both from our health system impacts and our social support systems and our societal support. I do want to highlight one thing. I don't know if you guys have heard about this. So Dr. Krumholtz mentioned that people need to feel like they're not alone. They are rolling out, just a few days ago, they rolled out a campaign in Missouri called Voices of Long COVID. And the goal is to increase public awareness of the impact and the unknowns associated with long COVID. About a third of American adults are unaware that it even is a thing. I think that number or that proportion is probably changing over time. The goal of this campaign is to encourage vaccine uptake, particularly among people aged 18 to 29. So they include testimonials from a diverse group of people. And this is part of a larger national campaign, but there is a campaign customized to Missouri, and the link is here. And so what they're really highlighting is 3 different stories. One's a 20-year-old Mizzou student and has trouble now breathing when walking and has severe memory loss. That's Caitlin over here in the image that I'm showing you. She talks about in her video that she has to write down things immediately when she thinks about them because she can't remember if she doesn't. Another 22-year-old who used to run 5 miles a day and now struggles to climb stairs. And then a 26-year-old Air Force veteran who's a part-time student and was an essential worker. And he now has a whole host of COVID-19 persistent symptoms that he's dealing with. So it's an excellent campaign, and I think it's going to do a lot for us to raise awareness. I think we've known about post-COVID conditions for a long time, but the public doesn't have maybe quite enough awareness. And we know that vaccine is preventative. This may be another opportunity to try to talk about the benefits of vaccination. And you can see here in Caitlin's quote, "I can no longer remember things. I'm telling my long COVID story so you won't have one to tell." So we'll see how effective it is. If nothing else, I think it's going to increase awareness of long COVID. So big picture, we know that we're looking at possibly millions of people being impacted by post-COVID conditions, lots more to learn. And importantly, this is not just an adult thing. It does affect children and adolescents. It's super difficult to study. There are some other CDC resources that talk about how we as a society can support people who might be experiencing post-COVID conditions, really thinking about listening and asking. And I think actually that's probably something we as a society need to do as a whole, and trying to listen with kindness and open ears and helping where there's an opportunity and an invitation to do so. Vaccination works. I think this is Dr. Comfort covered this. And then just a couple notes about the public health approach. So I'm an epidemiologist by training. There are a lot of people trying to figure out how we can provide better estimates on the prevalence and incidence of post-COVID-19 conditions, and importantly by demographic groups, since we know that there's some inequities that are likely to persist well beyond that initial infection. Looking at the course of illness and risk factors, providing guidance for people like Dr. Comfort and Dr. Krumholtz, evaluate models of care, and importantly, establish and maintain partnerships. If COVID-19 has taught us anything, is that public health and medicine are actually very, very close and need to be closer, and there needs to be cross-training in those. And one thing that I do is collaborate with other federal agencies and organizations. So there was the mention that NIH is pouring a lot of money into post-COVID conditions. One thing that I do in my role is to try to figure out how we can make sure that we're all talking and how working together to hopefully reduce duplication, but also to synergize our efforts to get more bang for our time and our money. So that's what I wanted to share. I know there was a bunch of comments and questions for Dr. Comfort in the chat, and I'm happy to chime in whatever, but I did want to stop here.
Wonderful. Oh, thank you so much, Dr. Satterwhite. That was amazing. This whole forum has been really great, and I'm glad we still have some time here to discuss some of those questions. I know we have some in the chat, but at this point I'm going to turn it over to my colleague, Pat McDonald, who's going to do some moderating of the chat, and I'm sure also she'll invite whoever submitted some of those questions to come off chat or come off mute if they would like, and ask the questions aloud as well. But Pat, it's all you.
Sure. Thanks, Stacy. And thank you all for your presentations. Thank you so much. This is incredible education for all of us. I start at the top where I see some questions. I see Karen Brayman submitted a question early in the chat. I'm not sure if it was particular to Dr. Krumholtz, but I will read it, and whoever feels that they want to jump in on any of these questions, presenters, just jump right on in, okay? Karen asks, are you seeing any trends on what treatments, therapies, or care may be effective in treating long haul COVID? Are you seeing any trends in anything in particular?
So Pat, I think I can answer that if Dr. Crumwalt isn't here, but the main trend that we've seen is really being this push and emphasis into rehabilitation efforts. And again, not because we think that's the only answer, but because it's the best answer we have at the moment. And then there's certainly a lot of promise, I think, as we get a better understanding of the biology of this. I think Megan really highlighted this well, right? That of a lot of the tools that we have right now, the tests come back normal, right? And I think a lot of times patients and providers alike can take that as there's nothing wrong with you, right? And we know that that's not true in long COVID. It's just that our tests aren't good enough to detect exactly what's going on. And so there's a lot of research efforts by really smart people that are trying to detect some of these subtle changes in the immune system and things like that. And so, my hope would be over time, I think this is probably where it's going, that there would be some sort of targeted treatment to try to calm down that inflammation, right? So the tools that we have now that are effective in really bad autoimmune disease, lupus, and those sorts of things are probably too strong for patients who have they're just not appropriate for our patients with long COVID, right? They'd be much more harm than good. And so hopefully, as we understand this better, that there's more targeted treatments. And I really see that being the direction over the long term of where it goes from a therapy standpoint.
Thank you. And thank you, Karen, for the question. Aditi Gupta also directs a question to you, Dr. Comfort. Do patients know that there are post-COVID clinics such as yours? Can we do more to spread the word? She believes that there are a lot of patients with symptoms who do not know where to go, or that clinics have been formed to start studying long haul COVID.
Yeah, great question, Aditi. So I think Dr. Sadoway highlighted this, right? A third of people in Missouri didn't know about long COVID or post-COVID conditions or something. So I think there's a huge misunderstanding in the public of just that this is even a thing. And so I think, there's probably a lot of patients who don't know about clinics like ours or around. There's been a lot of publicity efforts. And so, the Survivor Corps, which is one of the patient advocacy groups, they have a list of all the post-COVID clinics around the country, for example. And then there's been some kind of media efforts, at least kind of locally here, and I think nationally as well, to try to get the attention on that. We have tried. One of the things is, though, even if patients knew about it, we're going to have a hard time serving everybody. We already have more referrals than what we can see in a timely manner, and so I think that's going to be a real problem. We really need to have probably a widespread educational campaign to primary care physicians in particular. They're going to be in the driver's seat, I think, of the care a lot of the time. And then getting our specialty colleagues involved, when we need to, when there's something that they can offer that we can't. And so, we've tried to make some sort of effort on that, of trying to talk with other primary care physicians in the area, and done some CME talks and things like that. But I can tell you, we wouldn't be able to serve everybody. It's going to be a team effort of every single person in the health system, I think, to serve the need that's here and coming.
I just want to build just for a second on Brandon's comment. So I mentioned that we're worried really about health equity. I think this is going to be a huge concern. From the federal side, we will definitely try to encourage our federally qualified health centers to play a role. They do serve as the primary care or medical home for a lot of people. But this is going to be a huge equity issue as well.
Thank you.
Especially with our rural population too.
Yeah.
Yeah, thank you. You just answered my next question. That was my next question. What about people who are away from the metro area?
Mm-hmm. Yeah, and at least the post-COVID clinics that I'm aware of are there at like academic institutions actually most frequently, I would say.
Yeah, I think that's true. I would say that telehealth has opened up our world a little bit. So we've had a number of patients that we've seen that from rural areas that live 2 or 3 hours away. And it's been pretty effective. I mean, it's obviously not as good as being in the exam room where we can examine them and things like that. But in a lot of cases, I think as we've alluded to, that a lot of times, exam looks okay, the imaging, so it's really more at this stage, a lot of talking and kind of getting the workup. The history is really where the money is, and we can get that through a telehealth platform pretty effectively, I think.
I feel that education is lacking somehow. I mean, believe it or not, I've talked to some physicians who don't believe in long COVID either, because they're like, well, people have things. And now just because they had COVID, all these symptoms have been attributed to COVID. And I mean, it's I don't know. I just feel that there's more education which is needed.
100%, right? So I think doctors dismiss it. People in my own clinic, right? We're about KU internal medicine, right? We're doing this, and we have providers that tell me. I just had one of my providers, she's so good, and she was like, I've not seen anybody with long COVID. And I'm like, you haven't been looking, basically. I mean, it's there right in front of you. And so I think there's a huge education gap, Didi. I think it's a fantastic point that you bring up.
Thank you for that. There was another question. For Dr. Comfort and Dr. Satterwhite, does long haul COVID tend to happen more frequently when individuals had certain variants?
Oh, that's a tough question. Catherine, do you have?
Yeah,
so
the answer is we don't know. That's the answer. Because to sequence and determine, just from a research perspective, sequencing the strain that you were infected with is pretty laborious. And if some people are enrolled in a study, they may not still have virus in their system by the time they actually realize. So it depends on the study design. By the time they realize they have these post-COVID conditions that are persistent, I think we'll learn a lot in about 4 to 6 months. But we don't know, unless you have some crystal ball, Brandon.
No, I haven't seen anything on that, and I think we're just now seeing the folks who probably had Delta. I mean, we kind of assume based off of their timeline. And I haven't seen anything on it, and it's a very interesting question, though.
Thank you. In the survey of vaccine treatment, were all the outcomes self-reported?
Yeah, we should take this one with a grain of salt, but these were self-reported. No, this wasn't like a trial or even a retrospective analysis or something like that. This is people. I think one of them was on like the Survivor Corps, and I think there was another one. I wish Dr. Krumholz is still on, because there was a group out of Yale that was working on this exact question. I don't think they've published their results yet, but so that one will be very interesting because it's set up, I think, more in a standard kind of trial design or cohort design, at least. So yeah, we need to take it with a grain of salt, but there's certainly a signal there. And I've had just anecdotally, a number of my own patients in my clinic telling me that they get better with it. There are a few though that say that they get worse. And so it's a hard thing to do, but it seems like the vaccine does have some sort of effect on people's symptoms. And so it's certainly an area that needs to be looked at pretty closely. But I will say there's enough there that I recommend it 100% of the time with my patients and who have long COVID. And I can tell you a lot of our patients suffering from this, they're quite hesitant on the vaccine. And I get it. They're sick. They don't feel well. There's a lot of misinformation around the vaccine. And so I think there's a lot of so we always recommend it 100% of the time.
We have time for probably one more question. Audience, if you want to come off mute and ask a question, please jump in. Did I hear somebody unmute? Okay. Dr. Comfort and Dr. Satterwhite and Megan, do you want to make any last comments for our audience to leave with and think about as they go out in the snow?
Well, and we do have one more. I don't know if you wanted to address that.
Oh, one more?
Some of the symptoms
there we go.
Fibromyalgia sufferers, which also is sometimes misunderstood and ignored by providers. Do you see any correlation or connection from Chris Fuss.
Yeah,
So,
really great question. Yeah, I do. There's certainly some overlap with this. There was a really interesting webinar I listened to, put on by the Mayo Clinic, and they said they were going to publish this, but I haven't seen it yet. But it was so good, and they talked a lot about this idea of central sensitization, which is, you know, when the midbrain and the areas kind of get hyper activated in COVID, kind of like that fight or flight sort of aspect of the brain that gets really activated and it just doesn't settle down. So they had some kind of interesting kind of MRI studies that they were pointing to on that. But the point is that there does appear to be some stimulation or hyperactivity within kind of the midbrain area that can increase some of these symptoms of pain, joint pain, aches, and things like that. And that is probably a different biological process than what people are experiencing with the inflammation, or maybe they tie together, right? So if you have inflammation, it hurts at the, you know, in your hand or something, but that signal gets kind of increased, or the volume gets increased. So long story short, yeah, I think there is a lot of overlap, and it's made me at least think about fibromyalgia very differently than I had previously. It makes you wonder about where some of these conditions that we've struggled with for a long time, you know, where that etiology ties to, you know. And so yeah, there's a lot of overlap there, and it's really, really interesting. And then I think I'll just say my final words so we can make sure and give Megan the last word here. But I'll just say I really appreciate the opportunity to come and talk. We've seen so many patients that it's good to just hear other people talking about this, and especially hearing from patients and then from the public health perspective. But this is a very real disease. Very big problem, and we're going to have to figure out. We're going to have to all work together, I think, to take care of this. And this is going to be a problem for a long time to come. And so I just appreciate the opportunity to have a great conversation with everybody.
And I can follow Brandon. My last thought would be, it's a time to dig deep for compassion. This is not an easy thing to deal with. I think Megan illustrated that very, very well. And a lot of people might be in this situation where it's impacting them on a daily basis. So compassion and listening and recognizing people who share their stories about anything related to COVID. I know we've talked about people who share their vaccine story, why I got vaccinated. I think people sharing their long COVID story that we need to hear and listen with compassion. Thank you, Megan.
Yes, thank you all for listening. I just want to end with, I think focus on the why is like huge in this, and just focusing on what is making the immune response so great in certain people. Because I can say it is real. I was a very healthy person before COVID. In the struggle of being like an athletic and healthy person and trying to go to the gym and having like the muscle and joint pain and feeling so defeated, that messes with your whole mental health too. So I mean, I just want to say that thank you for all the work that you all have been providing or doing, and just keep it up. I don't even know what else to say, because there's just so much that still is so unknown, but I hope that everyone can figure it out together and figure out what's making the response so great in certain individuals. Yeah.
Thank you. Thank you all. Thank you for bringing us the numbers and the statistics behind it. But more importantly, or equally as important, is for reminding us that we're talking about human beings and people's lives and the quality of people's lives. So thank you for highlighting that, reminding us about the human aspect and the compassion we need to have for each other, because we're in a very unique time. So thank you all for that. We also want to thank our partners in our forums, BioNexus KC. Thank you all for your help. They're on the line. Several of them are on the line. Dennis Ridenour, Shaylee Young, and Daniel. I know you're out there. Thank you all for your help with these forums. We couldn't do it without you. Everyone be safe in the snow. Don't hurt your back. and drive safely and have a great rest of your day.
And we'll see you March 17th, Rural Health
March
Innovations.
17th. Yeah.
Yes.
Rural Health and Innovations.